Immunotherapy. I believe that we have to answer the questions in first line in immunotherapy in melanoma because it answers the questions for a whole host of other solid tumors. I do believe that targeted therapy only works in the long term if there's an immunotherapeutic aspect. So the MEK inhibitors and the BRAF inhibitors, there's an immune activation. And ultimately, this is not going to be a question in melanoma. Everything that's targeted is being combined with immunotherapy, and we're getting great results. Ryan Sullivan, who presented with me at this meeting, has presented triplet combination with BRAF, MEK, and anti-PD-L1 showing huge clinical benefit, and these triplets are already in combinations and in randomized trials. So I believe we will come to a point where the BRAF question in the first line will be obviated for a triplet combination. But the immunotherapy, this is where we need to figure out predictive markers, prognostic markers, toxicity questions, relevance of the appropriate patients, because it's our job to bring this data to almost every solid tumor. Combination versus sequencing will cease to be a question. Most patients are going to begin to get adjuvant PD-1. Whether it's lung cancer or melanoma or other solid tumors, the data is coming out. We have stage 3 data in lung cancer showing that adjuvant PD-1 is appropriate. We have data in melanoma, adjuvant PD-1 is appropriate. So by the time in the future these patients are going to come to see us, the majority will have already seen single agent. And we will have to understand the combination. So this question ceases to exist when you understand how much combination ability there is. It's not just anti-CTLA-4, anti-PD-1. It's IDO plus PD-1. It's oncolytic plus PD-1. It's LAG-3 inhibition plus PD-1. We have to find out when and where the right combination is appropriate. And Dr. Acierto has shown the data using LAG-3 as a predictive marker to response in PD-1 refractory patients. And we need to take that paradigm and utilize it at every single point when a patient shows up untreated and when a patient shows up either relapsed or refractory to PD-1 therapy. Is it combination? Yes, but what combination? That's the important question. As we tease this out, I believe we can only say that monotherapy will be appropriate for that patient that has the strongest indicators for response on a single agent. And what are those right now? We're quite unclear. Maybe it's high PD-L1 staining, low tumor burden. It'll be the person where you have clear evidence that you can salvage with combination. So you want to avoid toxicity. Although I will tell you that as we've refined our combinations, we have combinations with little to no additive toxicity. So at that point, it's not a question of why give combination because of concerns of toxicity. It's a question of, well, what's the next combination I give from this combination? The data for epacadostat pembrolizumab has really shown a very minimal increase in grade 3 to 4 toxicity. For me, that's enough to say that we should be treating every patient in that way. Because if you look at the breakdown of the subgroup analysis in LDH, M1C, BRAF mutant, it's similar to anti-CTLA-4, anti-PD-1, and the response rates are equivalent. Now, smaller subgroups of patients, but it is looking to be a promising combination to go forward with. And we've already done the randomized trials. Hopefully by the time we come back to this beautiful city in 1 year, if invited, we'll have data to present in a multitude of randomized phase 3s that'll answer all your questions. BRAF-MEK versus BRAF-MEK PD-1 in combination randomized. IDO PD-1 versus PD-1 randomized data. And we'll have a better roadmap. The questions will not be 1 versus 2. It'll be which 2 to start with to begin with, or which 3. This was very nice. Thank you for the opportunity. It's a nice